Hello everyone, I'm Dr. Binhi Desai, practicing ENT and voice surgeon at Desai Orthopedics and ENT Clinic, Borivali, Mumbai. Today I'll be talking about how to visualize the larynx. The larynx is also called as a voice box. So the functions of voice box are mainly three: speaking, breathing, and swallowing. So, if any patient comes with any of these complaints and we are thinking that the patient is having a problem at the level of the voice box, we need to know how to visualize it and we need to have certain tools to visualize it. So, before that, I would like to tell you where is the voice box located. So, here you can see that the voice box, which is marked in yellow, is located below the level of the jaw. So it is exactly located at this level. It is located below the level of the jaw, behind the thyroid gland, and above the breathing pipe area. So it is not possible to visualize this structure just with the help of naked eyes. We need certain kind of tools to visualize the voice box. So now a closer view. We can see that again the voice box is a structure which is located above the breathing pipe, also called as trachea windpipe, and behind the thyroid gland. This is the thyroid gland, which is the shape of a butterfly. Now we have understood that to visualize the larynx or the voice box, we require a high quality imaging, and this is a very prerequisite to come to an accurate diagnosis and to treat a patient with voice, swallowing, or breathing problem. Now, let us understand and know that how we have evolved from the basic mirrors which were there in the 18th century to stroboscopy, which we have today, which is the best technology to see the voice problems. So, first came in an indirect laryngoscopy in the 18th century. So, a scopy means to visualize or to inspect. Laryngoscopy means an instrument or an equipment which is used to visualize or inspect the larynx or the voice box. Indirect laryngoscopy was the first thing that came in 18th century. So in 18th century there was a lot of curiosity to know how we speak, and hence we they used mirrors to see this kind of a to mirrors to visualize the voice box, and in the mirror we got an indirect image of the larynx. We were not able to see the larynx directly, but we got an image which was collected over the mirror, and hence it was called as an indirect laryngoscopy. After this came in a direct laryngoscopy wherein we were directly able to visualize the larynx. Then came the flexible or the rigid laryngoscopy, and today we have the stroboscopy. Stroboscopy actually came in quite early, but because it has given us so much more, there has been so much of improvisation in the technology, and today we have the best technology of stroboscopy. So what would we see if we try to visualize the voice box? So the image on your left side shows us that this is how a voice box or the larynx looks on the side view. Uh, Here is the mouth area, this is the nose, and we will have to put something through the mouth or through the nose to get into this area. And two structures like this are called as vocal cords or vocal folds. Below it is the trachea or the windpipe. So when we insert something through the mouth or through the nose, this is what we will get. So white structures are called as vocal cords or vocal fold. So when you try to speak, both the structures will come close to each other and form a tight seal, and it will look like this, and hence we will say that the vocal cords are closed, the breathing pipe is closed, and when you try to breathe, of course it has to open up, and hence this is how it will look. So just keep this image in your mind. So now Now moving on to the first thing which came in the 18th century, which was an indirect laryngoscopy. So indirect laryngoscopy is a procedure in which ENT surgeons all around the world are very well trained. So in this, the patient is made to sit in front of you. The patient you can perform this procedure in your OPD setup. The patient will sit in front of you in a panting position, sitting a little bit ahead, tongue out, and with one hand you will hold the patient's tongue, and with the other hand you will insert a mirror which has been warmed. So when you insert the mirror, this is the image you will be able to collect on the mirror. If the procedure is performed comfortably, you will get a good view on the mirror, and you will get a view of the voice box, and the patient will say E. So when the patient says E, the vocal folds will come close to each other, and when he will breathe, it will open up. So you will be able to visualize the open and close movements of the voice box. So this is the exact position. The patient is sitting in front of you in a panting position, like with the tongue out. With one hand you're holding, and with the other hand you're inserting the mirror. So this procedure has certain advantages and disadvantages. So the advantages are mainly that it is an OPD procedure. You can perform it right there and then. It requires very minimum instruments. You can easily check for vocal fold mobility, and you can have a gross view of the larynx. But it does come with certain disadvantages. The most important disadvantage is that it's a very uncomfortable procedure to the patient. The feeling or the imagination that something is going inside the mouth, which is a little warm, it can be scary for patients. The patients who have a very strong gag reflex will not tolerate this procedure. Now, there is no level of magnification which can be achieved in the mirror, and hence you cannot do a detailed evaluation. You can neither record this view nor you can review this image, and hence it is it's a good procedure, but it does come with certain drawbacks. Now moving on to, we got direct laryngoscopy. So here on the left side you can see me doing a direct laryngoscopy. I'm doing actually micro laryngoscopic examination. So here the patient is taken into operation theater under anesthesia. You put in the laryngoscope through the mouth inside, and then you suspend the larynx and you visualize it. Here I'm also using a microscope, and this is the best microscope, Carl Zeiss microscope, which I'm using and trying to see. And this is the image that we get. So the image is far superior as compared to indirect laryngoscopy. Here you can even improve the quality. You can use the rigid scopes inside to visualize the undersurface of the anterior portion or the posterior portion. The patient is basically under anesthesia, so you can utilize the time with a lot of other equipments and try to visualize and do further more things. So the advantage of this procedure is here you can not only visualize but also you can perform procedures. But the disadvantage is main is that the patient has to be taken under operation theater. You have to give anesthesia to the patient. You will be putting a scope through the mouth, so there is a risk of injury to the teeth, lips, because there is a little bit of a pressure over the tongue. The tongue after the procedure can become a little numb. So then moving on to, we have the flexible laryngoscopy system. So this is my personal favorite, and this is how it looks like uh, on visualizing the scope. And on the left side you can see me doing the procedure. The patient is seated comfortably in the minor procedure, and I've inserted a small scope through the nose. The patient is very relaxed. I don't have to give any and gentle anesthesia to the patient. The patient is comfortably sitting in front of me, talking with me, and I put in the scope through the nose, and through the nose, behind the nose, mouth, throat, and that's how I visualize it. So on the right side, you can see me holding the scope. We have the best Olympus flexible and rigid system available with us. So this is a video of what we will be able the behind of the nose, which is the nasopharynx. This is the palate area. This is the tongue area. See, while I'm entering, I'm also inspecting and seeing for things whether everything is okay. This is an epiglottis or the small tongue. So this is the larynx or the voice box. This is the food pipe area. And what we need to understand is that your left is patient's right and your right is patient's left. Okay. So the white structures you can easily visualize. What you can visualize is that the right side is moving, but the left side is not moving. So when the patient is breathing, this is short and this is long. I'm saying E, the gap is there. So the patient has a left-sided reduced mobility. So flexible laryngoscopy system is a main workhorse for laryngeal examination. It is by far the main instrument to visualize because it has far more advantages. It can be performed even in children, and those patients who have a strong gag reflex can be, will well tolerate this procedure. It is a portable system. You can move, travel, you can get it to other various hospitals. Patient will be singing, talking, so you can assess when the patient is trying to speak, when the patient is to sing. You can also perform certain procedures such as injections, biopsies. The patients who have no mouth opening, in those patients, when you take them into anesthesia, putting an anesthesia tube can be very challenging, and hence, with the help of a flexible system, you can put in an endotracheal tube through the nose. With the flexible system, you can go as close to the lesion as possible and inspect it well. So what are the disadvantages? The disadvantage is that it is more expensive as compared to an indirect laryngoscopy. Now, the image quality that you get has certain features. One thing is a barrel effect. So here, if you will try to see the image on the left side, it looks as if the center part is close to you and the periphery is distantly away. So this is basically a barrel effect, and it also has a vignetting. So vignette is one of the filters in our phone that we have, and we know that in the vignette effect the center part looks bright and the periphery looks darker. So that is the quality that you get. The more close you get, the more is the effect. So the image quality is inferior to that of a stroboscopy system. So then we have the rigid laryngoscopy system. This is a rigid instrument which goes in through the mouth. So you can see me performing. It goes through the mouth and the patient is comfortably seated in front of you, and you try to visualize the voice box. So this is a video. You have put in through the mouth. You can see the tongue, the small tongue. This is the white structures, which is the vocal fold. Behind is the food pipe area. And you can see certain small structures which are hitting each other, and this patient seems to be having something called as vocal nodules, which is very early, and that is the reason for his voice problem or hoarseness. He also has a little bit of a gag, and hence she's not tolerating the procedure that well, but we are getting a good view of the voice box, and you can see that white structures are hitting each other when the patient is trying to say E. So when they are coming close to each other, the patient is saying E, and that is the only vowel you will be able to check. because you're holding the tongue. There is no other alphabet or there is no other thing that you can check in rigid laryngoscopy. So the main advantage is that the image quality is far superior as compared to flexible system. Certain lesions can be well visualized with the rigid laryngoscopy system. Certain procedures can be clubbed with a rigid laryngoscopy system. Again, the disadvantage and the main one is that the patients who have a very strong gag reflex will not tolerate it. So again, you're entering through the mouth. It is a little bit of a scary feeling for the patient that you're putting rigid structure through the mouth, certain big instrument through the mouth. It is not a very uncomfortable feeling for every patient. And the only vowel you will be able to check is E. That's it. No other vowel you will be able to check. And hence, certain movement disorders, certain functional disorders, certain neurologic conditions where you want the patient to sing, you want the patient to say certain speech, we will not be able to assess it. And for that, we require the flexible system. So before I had did not have a stroboscopy system, I was doing the flexible and the rigid laryngoscopy system for all my patients with the intent that the disadvantage of one will be taken over by the other. So with that, I used to get a complete evaluation of the patient who was suffering from voice swallowing or breathing difficulty. But now I have the best system, which is the stroboscopy system, to assess any patient with voice and swallowing problems. I do have all other systems as well. Because stroboscopy today is the gold standard, I have made a dedicated video for the same, which will be coming up after this video. So thank you for your kind attention and do stay tuned to know more about stroboscopy. Your questions, comments, suggestions are most welcome. Thank you so much.